Welcome, everybody, to Lifestyle Medicine Grand Rounds, a co-production of Rochester Lifestyle Medicine Institute and the William J. Folletti Center for Lifestyle Medicine in Ann Arbor, Michigan. I'm so excited to be able to welcome you to this really what I expect to be a really interesting Grand Rounds called High Intensity Lifestyle Medicine, Safe and Effective or Dangerous and Foolish. A little bit about RLMI. We'd love to help you empower your patients. We have a number of Zoom-based facilitated programs that build motivation and competence in a socially supportive and interactive environment. Our programs are ACLM certified, and if you are interested in referring one of your patients, you can go to our website, and there are online forms. There's also other ways to get your patients to sign up, but we do have an online form that if you fill it out, we will contact your patient for you. Some of our regular programs, 15-day Whole Food Plant-Based Jumpstart, the LIFT Project, and health coaching. If you notice the top line there under Jumpstart Program and the LIFT Project, it says 10 CMEs. That means that if you are a healthcare professional and you sign up for the program and go through it along with patients and other participants, you will receive 10 CMEs. The programs are certified by the Rochester Academy of Medicine for CME credit. As I already said, we do have a number of CME programs, including one up to 24 CMEs called Jumpstarting Health. And also, please respect the privacy of the patient that will be presented, although Dr. Kelly has done pretty much everything he could to make it impossible for you to figure out who that person is. And speaking of Dr. John Kelly, he's our case presenter tonight, known as Dr. John. He completed his undergraduate studies in biochemistry and molecular biology at Shepherd University. He completed the dual MD MPH degree program at Loma Linda University in epidemiology. He is trained in preventive and lifestyle medicine and has done private and government-funded research in lifestyle medicine. He was founding president of the American College of Lifestyle Medicine, co-authored ACLM's official board review course in lifestyle medicine. He serves on ACLM's expert panel and is on the adjunct faculty at Loma Linda University. He has published peer-reviewed papers on reversing type 2 diabetes with intensive lifestyle medicine treatment. And Dr. Caldwell Esselstyn received his BA from Yale and his MD from Western Reserve University. He won a gold medal in rowing at the 1956 Olympics in Melbourne, Australia, and served as an Army surgeon in Vietnam, earning a Bronze Star. Since 1968, he has been affiliated with the Cleveland Clinic, where he has held various leadership positions. Dr. Esselstyn has published over 150 scientific works and conducted significant research on reversing coronary artery disease, detailed in his book, Prevent and Reverse Heart Disease. His studies have shown that a plant-based diet can effectively prevent major cardiac events. He has received numerous awards, including the Benjamin Spock Award and the Lifetime Achievement Award from the American College of Lifestyle Medicine. He currently directs the cardiovascular prevention program at the Cleveland Clinic, Cleveland Wellness Institute. Dr. Esselstyn and his wife, Anne, have followed a plant-based diet since 1984. Our regular panelists tonight are Dr. Robert Breakey, who is board certified in family medicine and lifestyle medicine. He has been a family physician in Ann Arbor for almost 40 years and serves as the medical director for IHA's William J. Folletti Center for Lifestyle Medicine, as well as the chair of IHA's governing board. He is also on the board of directors for several national organizations, including Rochester Lifestyle Medicine Institute. He has a special interest in employing lifestyle medicine approaches for disease reversal. And Dr. Melissa Sundermann is board certified in internal medicine and lifestyle medicine and has practiced for over 25 years. She has also has training in integrative medicine and mind-body medicine. She is known as Dr. Outdoors and is the founding chair of the Nature as Medicine subcommittee for the ACLM. Dr. Sundermann currently specializes in lifestyle medicine with lifespan medicine. She previously practiced lifestyle medicine at Canyon Ranch in Lenox, Massachusetts, and IHA in Ann Arbor, Michigan. In addition, she is chair of the Global Wellness Institute Lifestyle Medicine Initiative and co-founder of Revive Lifestyle Medicine Wellbeing Coaching. And Dr. Carrie Graff is our case coordinator, and she is the medical director for RLMI, and you can read her biography there, and you can read my biography there as well. I'm very pleased to introduce our panelists tonight. And just a reminder, we are a nonprofit. If you'd like to make a donation, you can aim your phone at that QR code, or Bob will put a URL in the chat for you to click on. So, high intensity lifestyle medicine, ITLC, safe and effective or dangerous and foolish. And I'm going to stop sharing, and I'm going to ask Dr. Kelly to start sharing, please. So welcome panelists, welcome Essie, welcome Melissa, welcome Bob Breakey, welcome Dr. John Kelly.
Thanks for having me. And this is a privilege to be on the Rochester Lifestyle Medicine Institute cases. So I'm going to talk about, indeed, a health guest that we had in our Start a New Me program. some time ago. Of course, I'm not going to tell you when because I'm trying to keep this all anonymous. Do have the patient or the guest's permission to share this information with you.
Great.
So let's get my pointer going here. So I'd like to start off with just some thought questions here. We're not going to do a poll, but we're going to use it to get our, like I say, to get our thinking cap going here. So these are true or false questions. So first one, there is a threshold effect with lifestyle change therapy that requires some minimum amount of change before therapeutic effects are evident. True or false? Is there basically a threshold effect or not?
So why don't you read, let's go through all three questions and then I'll go to the panelists, okay?
All right, very good. And then the second question is, the therapeutic effects of lifestyle change therapy are primarily the results of changes induced in gene expression or genomics. True or false?
Okay.
Third, therapeutic changes in gene expression happen slowly and require weeks or months to achieve. True or false?
All right, I'm going to ask Dr. Sundermann to please weigh in on those.
Wow, we started off right away with a quiz, Dr. Kelly.
It gets most people's attention.
Yes, it does. So when I look at these questions, I think that I'm going to start with number one. And is there a threshold effect that requires some minimum amount of change before therapeutic effects? So I'm going to take that as when I've seen with my patients, therapeutic effect meaning what? Sometimes if we're looking at biometrics or are we looking at just like how they're feeling, like in terms of wellness, and sometimes just really small early changes could manifest, right? Of just going more plant-based or just moving their bodies more. People will say, I'm sleeping better. My mood is elevated. So is there a threshold effect? There's likely a threshold effect to see statistical evidence, but I've seen in my patients that within a couple of days of making some small, subtle changes that they're coming to me and something's changed and they're feeling better. And when we talk about number two, what I'm really looking at is the field of epigenetics, right? And that we know that genes are not our destiny, and we have the ability to turn on or off gene expression through lifestyle behaviors. In terms of epigenetics and in terms of things like gut microbiome, we have studies to show that within days or even a week or 2 weeks that we're seeing changes that happen at the gut microbiome level, at our epigenetic and how the genes are expressed. So I don't think it takes weeks or months to achieve. We see changes that happen quite quickly.
Very good.
Yeah, Dr. Breakey.
Yeah.
So yes, number one is definitely true. And it, as Melissa mentioned, it varies depending on the person, where they're starting from, where they're going to, and what their goals are for therapeutic effect. Number two is false. These can take effect, some changes within hours. I'm sorry, the therapeutic effect is definitely in part due to gene expression, but I wouldn't say primarily. And therapeutic expression can happen quickly. So this one can be sometimes hours to a few days for epigenetics and gene expression to begin to change.
Great, thanks for that. Dr. Esselstyn, your thoughts, please.
Yeah, I think later on in the program here, you have a slide that I have of a PET scan. And the PET scan, we were able to show there was an area of ischemia at baseline.
Right.
And then that was at the same time that I counseled him. And we repeated the PET scan 3 weeks later. And the area that was ischemic was now completely resolved. And the fact that we did it in 3 weeks, obviously that was just when we identified it, because if we had done the follow-up PET scan earlier, who's to say that it hadn't happened even earlier? So and the thing about that PET scan was that we we know that we didn't really resolve any significant PET scan that's in any significant type of blockage in a main artery. That certainly didn't go away in 3 weeks. And when we first see these patients, their endothelial production of nitric oxide is markedly diminished. And believe it or not, at that same time that you see these patients, your endothelial cells are now your enemy. they're producing two molecules that are vasoconstrictive, endothelin and thromboxane.
Mm-hmm.
It seems to happen as you begin to get these people to change to whole food plant-based nutrition, they immediately begin to start recovering and making more of the vasodilator. And most importantly of all, those thousands upon thousands of really interdigitating small intramuscular arteries, which are in spasm because of the endothelin and thromboxane, that as the endothelin and thromboxane goes away, suddenly this entire intramuscular cascade of vessels begins to open up, and then we got the whole business of Poiseuille's law of flow through the hollow viscus. It's related to the force power of the radius, which is why some of these patients as early as 2, 3, or 4 days begin to get rid of their angina.
Right, right. Yeah, fascinating. Thank you for that. How did they do, Dr. Kelly?
Oh, I think it was great and quite
Great.
educational. So I'm going to move past these questions and go right into the case presentation. So
Okay.
what I have here is basically I'm going to show you 6 of the 112 or so Start a New Me program participants with excellent results in their first couple of weeks. So there's 3 shown here. At the bottom of that slide, you can see there's a minus 26%, minus 22, minus 33. That's the average percent drop of these beginning measures in these individuals. So you can see I've arranged them so that they get more impressive as we go. But the one that we're going to talk about is just this one on the far right here, ID number 115. This 65-year-old female with a BMI of 38. You can see at the bottom, she had an average drop of 58%. That's an average drop of 58%. And if you notice up at the top here, it was a 14 days between blood tests on this individual. So it's quite remarkable, but not a fluke. You see, we've got the one here in the middle is 39%, almost 40%. What I want to do now is just I'm going to focus on this case 115. That's our purpose today or tonight. And you can see the medications are listed there on the right-hand side of this slide. The date, I was asked about the date. I took the year off, again, trying to make this so it's impossible to identify this person. So I'm not telling you what year they went through the program. This individual did not have any change in the dosing in the 2-week intensive intervention. All right, let's talk about her. 65-year-old Caucasian female. Like I said, a BMI of 38.2. She's married with grown children. She consumes a standard American diet, basically meat and potatoes. She and her husband both have poorly controlled type 2 diabetes with neuropathy, handicap. She uses a handicap placard. She uses a walker or a 4-footed cane. At times she has poor balance. One of her major complaints was she can't walk her dog, whom she really loves, for fear of falling. She works part-time, however, as a stocker at a retail store, about 12 hours a week. Her sister is interested in health and urged her to take the Start a New Me program. This is an intensive lifestyle intervention program I was doing here mostly in Michigan. Her chief complaint was basically no energy. Says, I'm always tired. I can't get any sleep due to leg pain. I keep waking up. And my husband says I'm grouchy, but he massages her leg. And it, probably it's a distraction from the pain, but anyway, and then she sleeps a while longer. Her medical history is significant for heart disease, coronary artery disease, for which she had a stent placed some years ago. She has hypertension on multiple medications for these things. She's hyperlipidemia, high triglycerides, and other fats. She has obesity, and of course, the type 2 diabetes that we already mentioned. She has some pretty severe pedal edema with difficult, her feet hurt. That's why she doesn't work but about 12 hours a week. She has chronic pain. She has some osteoarthritis, and she has, of course, the diabetic neuropathy. She's got some allergies. She takes medication for. Her hearing and eyesight are unremarkable. Interestingly enough, she does not wear glasses even. She's a non-smoker. She does not drink alcohol or use any recreational drugs. Her vitals on intake were a blood pressure of 161/105, which was taken more than once to make sure we had it right. Pulse 65. Her weight was 229, and her BMI I already mentioned, 38. So I want to have a little pause and ask, what lifestyle history would you want for this lifestyle medicine patient? I don't know if we want to do any discussion about that, Ted, or not, but
Yeah, absolutely. Dr. Esselstyn, is there any other history that you would like?
Yeah, I'd like to know what was it that she weighed when she was 19?
well, I'll have to tell you that's a wonderful question, but I don't know, except I saw a picture and she was not heavy then.
I'm trying to figure out when she had the onset of her type 2 diabetes.
She's had type 2 diabetes for over 15 years.
Yeah.
So she got it somewhere in around her 50th year.
And what did she weigh then?
I don't know the answer to that.
Okay.
Dr. Breakey.
Well, along the lines of the pillars, of course, we want a little more about what standard American diet means. A lot of people say meat and potatoes. I tend to use a 4-leaf survey with my patients just to get some idea of kind of where they score 1 through 4 leaves or negative. And along the lines of the other pillars, what's her activity level? How is she sleeping? Is she doing any certain techniques to manage her stress? So all these will be important as we kind of help think about what's the root cause of her challenges. I think, as commonly the case, it's going to end up riding squarely on the back of the standard American diet, but all will be important.
Great. Dr.
Yeah.
Sundermann.
So I think I agree with Dr. Breakey, and I really enjoy, or I like to use the 4-leaf survey too, because I think it's gets individuals to think about their dietary habits. I guess a question I want to ask along kind of what Dr. Esselstyn was saying is ask her, like, when is the last time you remember feeling well? When was that? Was that not in your 30s? Was that in your 40s? When did all of this start? Because looking at our history and looking at our medications, I mean, these are all interrelated and all chronic diseases and all metabolically associated. So when did you last feel okay? And this is a classic pill for every ill as well. So I think sometimes to use those motivational interviewing and get her to connect with, yeah, actually, I felt okay until I was this age or this happened. So I would maybe ask a little bit of that motivational interviewing.
Well, what I'd like to emphasize is that I think anybody who has ever had cardiovascular disease on the planet Earth, at one time, they did not have that disease. And I think this is so important when you're starting to talk with these patients, to have them understand, okay, you were in your 20s, you didn't have any of these diseases. What was it that you changed in your lifestyle that brought about this disease? Because once they can buy into this, that a sense of responsibility of why they acquired this disease, then you get much closer to what is actually where the rubber always meets the road, which is how do you get them to be compliant?
Yeah, thanks for that. Dr. Sundermann, could you just remind people what the 4-leaf survey is for people who don't know?
Yes, the 4-leaf survey, Dr. Graff is who introduced this to me and Dr. Breakey, and it's a great tool that you can do within right in your office. And it basically is asking about their dietary patterns. And usually when I would have them do it, I would just, bring it up on my laptop, face it to them, maybe even leave the room for like 5 minutes. And it really quantifies, fruits and vegetables and whole grains and processed foods. And then it gives them a score. So it's not shaming, it's not judgmental. It doesn't say good, bad, or anything like that. It basically gives them a score. And then you can use that to track, right? To see progress or, repeat it every couple of weeks. We used it Dr. Barnett, when we were doing the Jumpstart program, it was just a good assessment to track and see how individuals are doing.
Right. Thanks for that. Yeah, and Dr. Graff put the link into the chat, so if people want to take a look. And Dr. Graff was instrumental in introducing that to the world, along with J. Morris Hicks. Okay, back to you, Dr. Kelly.
Yes, thank you. That was those are some good thoughts. I put a few things here. Social history, is married for many years, grown children, doesn't go out much. She is close to her older sister and they communicate regularly. But I appreciated the many other things that were brought up. This was just, so the next thing I wanted to ask is, what about labs? What particular labs would you want? And keep in mind, this is in a group intensive lifestyle program. This is not a one-on-one patient that you're, seeing in your practice. So we're using the same basic set of labs for a group of somewhere between 10 and 15 people at a time. So we want to discuss that at all?
Yeah, let's go for it. Dr. Esselstyn, any particular labs that you like to see?
Well, we can get some idea about a lipid panel, glucose, A1C, LP small a,
Mhm.
and if we have the information already that she has cardiovascular disease, it might be fine to follow this down a little further with a CT angiogram. Isn't this a patient who was 65 who was diabetic and had coronary artery disease and had a stent?
That's
Correct.
right. Yeah, that's correct.
All right.
So Dr. Esselstyn, it sounds like you're a fan of CT angiograms now.
Yeah, it would be nice to know what year she had the stent, because obviously if she had the stent, she had an angiogram, but I'm
Right.
assuming this is some years later on and you're going to document further disease progression.
Right. Interesting. Yeah. Dr. Breakey, your thoughts on labs?
I would agree with those labs. I'd also add a vitamin D and B12, just as as folks get that age, harder to absorb B12, and as we're looking to a healthier diet, not so much dietary wise, and especially living up north here, vitamin D can be a challenge. And then some inflammation markers, HSCRP, CRP. For a while, I was getting IL-6, but I didn't find it very useful. But these can give you a sense of just her levels of systemic inflammation. And otherwise, I agree with Dr. Esselstyn. I wouldn't tend to jump right to a CT angiogram, potentially a coronary calcium screen being less invasive, but have to interpret with caution. You can have a high calcium score. These are all stable plaques and not likely to rupture. Or you can have a score of 0 and still have unstable plaques. So you have to interpret it in context of everything else and being careful about either over diagnosis or over reassurance from that test. But in select people, it can give information inexpensively and with not near as much radiation.
Okay, well, thank you for that. Dr. Sundermann.
I agree with all of those assessments. I would add additionally fasting insulin level. And if we do have an NMR lipid profile, that would give us our insulin resistance score, as well as LDL particle size, maybe lipoprotein B. And then speaking to the stability of coronary calcium versus stable, unstable plaque, we could do it clearly, which really it's expensive. So you have to keep that in consideration. But that would give us a little bit more information about stability of the plaque.
Great, thank you. All right, Dr. Kelly, back to you, please.
Yeah, thank you. Those are all good ideas. One thing I should mention is that this was a community program. And so basically we were trying to keep the out-of-pocket. This is not covered by insurance, in other words. So we're trying to make it as inexpensive as possible. Would have been great to get some of those labs. These are the ones that we chose. You can see many of the same ones that the experts mentioned. And let me just show you here what the labs were and explain briefly. So yes, like Dr. Sundermann said, we want to get a B12, I guess maybe that was Dr. Breakey, but anyway, a B12 and a D25. We're partly because we're going to be putting them on a totally plant-based diet, and we don't want to do that if their B12 is low without supplementing. And the vitamin D, there's so many people are low on that, and it has so many potential metabolic effects. We just like to assess it. I would say over half of our people are marginal or low. Thyroid stimulating hormone, again, we want to make sure we don't have anything metabolic going on that's affecting their weight and difficulty losing weight. We get a CBC with differential. That's really more of a screening, but it is also important to know if you have anemia. if you're going to be trying to have people exercise and they say they're tired and can't exercise, I mean, you don't want to expect someone that's anemic or borderline to do this without just, discovering it. And we have actually found a couple of times some people that had some kind of bone cancer or metabolic difficulties and referred them for. We get the comprehensive metabolic panel 14. This is really has many factors that we want to screen, from liver function to the glucose, etc. Then the lipid profile is we always get this, and insulin. In this particular case, I don't always order insulin, but a person that has diabetes or has a finished diabetes risk score, fin risk above 14, I order the insulin, and always get the high sensitivity C-reactive protein, also called cardiac CRP. So there's the ones that were spotted in this case that were problematic. You can see the vitamin D well below 20, glucose over 250. I mean, that's quite high, and she's on medications, multiple medications. Ratio, total cholesterol to HDL ratio is quite high. I mean, I realize many people seem to think that 5 is not that bad, but from Mike's, what I'm aiming for is 3 or less. Triglycerides pretty high, and then the CRP not quite 4. So quite a bit of things that she can improve on. So another pause. What further lifestyle? Yeah, go ahead.
I just had a question. Do you think it would be appropriate to at least to get a one-time LP small a?
I do think that there are patients I would love to have that on, but it's not part of our standard lab set. But where I typically will do that, Dr. Essie, is to when there is a after I get the labs, I see something that makes me want to look further. I don't put it on the initial set of labs, but we do sometimes order it. Again, like I said earlier, we're trying to keep this community programs to be affordable for even the people that are not very high socioeconomic level.
John, one other quick comment on this. A hidden gem within this lab panel is actually the WBC count, which can be a marker for systemic inflammation. The usual range is between 4 and 10, but we find that people well within that range, over 6 to 10, have an increased risk of cardiovascular disease and of all-cause mortality. So if you're looking just like with cholesterol, normal isn't what normal American is. The normal range really should be 2.8 to 6.0. And this measure of 7.2 for her WBC, like the elevated HSCRP, portends an elevated systemic inflammation, which can also be reversed with what the interventions you're going to do here. So in addition to looking at anemia, I agree that that's another easy, good test to do and can help us a lot.
Yeah, thank you for bringing that up, because you're right. It's interesting how as people go on a plant-based diet, their WBC count drops significantly.
Yeah, we've certainly seen a number of, not to name any names, but my wife got worked up several times for having a low white blood count. It was in the low 2000s, and it was just completely normal. But nobody's used to seeing that, right?
That's so true.
Yeah, but let's go back to the LP little a. Dr. Esselstyn, do you feel like that's an important test, the LP little a?
Yeah.
Okay. What do other panelists think?
Yeah, I want to follow up on that, Dr. Esselstyn. So I agree. I think it's important because sometimes we'll have individuals who feel like are doing a really good job with lifestyle. However, you check this marker and it seems to run, they have a family history of heart disease, and this seems to be more hereditary. It seems that treatment of LP little a can be difficult. And I'm just wondering, in your clinical practice, how much intensive lifestyle intervention is able to nudge that, or if someone has an elevated LP little a with evidence of coronary disease, do we need to be looking at, and we don't really have a medication either that addresses that. Do PCSK9 inhibitors seem to improve that? Does lifestyle nudge that down? What do we do when we have an elevated level of LP little a?
There is there's a paper by, I think it was by Baxter Montgomery. It's in 2018. That showed that in a, can't remember the particulars of it, but I remember coming away with the fact that a plant-based nutrition could lower the LP small a about 20%.
Hmm. Okay.
And sometimes that can be pretty exciting to to stabilize or nudge that. The other thing that makes me a little puzzled about LP small a is that there's the word is out that most cultures will have at least 20% of their population will have an elevated LP small a. But you know, that kind of makes me curious about what's the rate of heart disease in rural China, the Papua Highlands, the Tarahumara, Central Africa, and so forth. Where is all the LP small a that's killing those people? I don't see it. Why not? Why not? Maybe it's not expressing because maybe not expressing because those cultures are eating plant-based. And when you look at the paper that you mentioned earlier that we wrote in 2014, of the 177 patients who were following the program, there was not a single a major cardiac event, heart attack, stroke, and death. And so it was really interesting that when you think about it, 20% of that group, we never checked their LP small back then, LP small a, and that 20% would have had to have had an elevated LP small a risk factor, but it didn't. But the plant-based nutrition when they're on apparently made it so that they were unable to express any disease progression.
Right, right. Interesting.
Yeah, I think this is a great example of genetics slows the gun and diet pulls the trigger. And just like the ApoE4 gene has the highest incidence in parts of Africa, but the lowest incidence of Alzheimer's, the diet can help offset that. So I agree with Dr. Esselstyn that it's important to check this in select cases and people who have stent and coronary artery. It's good to know, but don't keep checking it. It's like a HLA-B27 and people with back pain. You want to know whether they have ankylosing spondylitis, but don't keep redoing it. I have seen evidence, as he mentioned, that up to 15 or 20% lowering may be helpful, but some people have a number of 100. And, lowering it 20% to 80 isn't going to make a huge difference at this point. Now that may, though, what I commonly use it for is, okay, here's another important risk factor over which you don't have control. All the more important that you go on a more strict whole food plant-based diet to lower your systemic inflammation, to get your cholesterol as low as possible, to get your Dr. Esselstyn's favorite nitric oxide working right. And you will be able to offset that genetic risk over which you have little control. Now, this all may change in a couple of years. There are a couple of drugs in phase 3 trials that are showing promise, and we'll have to kind of reassess our both testing and therapeutic for LP(a). But in many ways, it is very helpful to just to know whether they've got that also. And I found it doesn't necessarily correlate with familial hyperlipidemia. Some people have high cholesterols of 320 and normal LP(a), and some quite the opposite. If they've got coronary disease, though, I do check it routinely and use it in that manner.
Okay, thanks for that. All right, Dr. Kelly,
All
get us
right.
back on track.
Yeah, let's get so further assessments. I use the SF36 and the Beck 2 scores from quality of life and depression screening. And I also do lifestyle habits. So we assess diet, activity, sleep patterns. In particular, I'll show you that instrument that we use here. And then this is the score on the SF36 and Beck score. So you can see, if you're familiar with the SF36, which is a validated instrument, that's why I like to use it, because I ask every patient for permission to do anonymous, use their data in anonymous research. So I like to have a good instrument. Anyway, you can see here that the total score, let me see if I can, my pointer, not
Yeah, that's
seeing
good.
my
We can see
pointer.
it. We can see it. We saw it there.
Okay. I can't see it. I'm glad you can see it. Well, anyway, the total score is 28 out of 100, so it's quite low. And but interestingly enough, the depression screening score was a raw score of 13, which is not even into the mild. It's over 13 for the Beck-2 is an indication of perhaps mild depression. So this was the screening tool that we use. Don't try to read this. It's been blown up so much it's blurry, but it just illustrates that we have a instrument built into the electronic health record for a lifestyle assessment, and it pulls in this data on dietary items. We don't do try to do a comprehensive dietary summary. We do what's called more or less like trigger foods, so we can identify a dietary pattern. That's on the middle left over here, and then in the I'm sorry, on the left side, lower left. Then in the middle, to the right of that, is we're looking questions about their meals and eating and sleeping and stress, work, and various questions of that nature. And then on the far right bottom part of this slide, we have the exercise that they can answer, breathing, and so on. So anyway, we do have a assessment. This was basically built around the original coronary health improvement program that Dr. Deal had. He gave me permission to start with that, and I expanded it and built it, automated it. Okay, so now what about the treatment plan? So I've listed here the 6 different pillars of lifestyle medicine. I like to think of them as domains of lifestyle medicine. But anyway, and I think that they're in general, I find the importance or the power, the potency is nutrition seems to have the most impact. Exercise or activity maybe second, rest and sleep third, resilience, how we handle stresses in life, and then connectedness and risky substances. Do you want to make any comments or ask any questions about that before I go on to the rest of the assessment? I don't know how much our time is looking.
Let's keep moving.
Okay, yeah, it's 8:12. All right, so this was, I already showed you this slide. That was where we do the assessment. Well, on the bottom of that is where we have the recommendations that we give. And so you can see this person was counseled to increase daily water intake, to lose 97 pounds. Of course, that's a scary number, so we always tell them 8 to 10 pounds a month. Reduce or eliminate salt intake because they're hypertensive, increase aerobic walking, exercise, and so forth. I won't go through it entirely, but there is a handout available, and you can get these if you want to look at this in more detail.
Yeah, so you're going to make the handouts available, and we'll send them out to the people who are signed up for the program.
Yes. So Marion already has those.
Great.
I've sent them. Anyway, and at the very bottom, notice this says see your physician. So this individual's blood sugar and blood pressure were of a nature that we recommend that they let their physician know about this immediately, because again, this is not a practice. This is a lifestyle program, group program for the community. We work with them for basically 2 weeks, and then send them on to their physician or whatever for ongoing support and maintenance. So I think, I'd like to just read these questions. I don't know if we're going to want to discuss them or not, but I think these are some interesting thought questions. The maximum change in biometric risk factors, such as blood test, is about 25 to 30% a month. Is that true or false? The maximum change in biometric risk factors, like blood test, is about 25 to 30% a month. True or false? Number 7, lifestyle changes are difficult for those with extremely high baseline values to make, and they cannot achieve as much change as those with more moderate baseline values. True or false? So lifestyle changes, are they more difficult in those people with extremely high baseline values? And is, in fact, those individuals not able to achieve as much change as people with more moderate baseline value? True or false? And the last question on this section, the most common medication dosing error during lifestyle change therapy is stopping medications too early. True or false? The most common medication dosing error. You want to discuss some of those?
Yeah, I'm going to turn that one over to Dr. Sunderman.
All right. Well, again, I'm going to reflect and draw on my own experience in the clinic. And I've seen, after I've had patients go through Rochester Lifestyle Medicine Jumpstart 14, 15 days and repeating biometrics, I've seen really incredible responses that have been over 25 to 30%. So I'm going to say false to that one. Number 7, false. I think that anyone given the opportunity, the support, the education can make changes, right? And we need to believe in that no one, we can look at on paper and this woman and say, my gosh, she's on 14 medications. She's got all of these chronic conditions. She doesn't want to change, and just write her off. And so we never should do that. So I think if you ask anyone, would you want to feel better? Of course, I believe that everyone would. They just need the guidance with what Dr. Kelly's been able to do. So false. And then the most common medication dosing error is stopping medications too early. In my experience, again, when people make small incremental changes, small changes, we will see blood sugars plummet very quickly. We will see blood pressure go down very quickly. So there's a bigger risk if we don't address this, that they could die from hypoglycemia. They could die from falling over of hypotension. So I think we always want to anticipate that if someone is following and making these recommendation changes, that we may say changes very, very quickly. So I'm going to go at false cubed times 3.
Okay. Dr. Esselstyn, you have any thoughts on these questions?
Well, I was just thinking about the fact that I think she answered those beautifully. I have a thought, and that is that I wanted to share. Maybe you all know this, but when I was working with trying to understand why our PET scan had worked within 3 weeks, I got I think it was my son who sent me an angiogram that beautifully outlined, which you rarely see, beautifully outlined all those intramuscular small vessels. And I called Rodriguez, who is the chairman of the Cleveland Clinic Cardiovascular Pathology, who dissects possibly 200 hearts a year from the deceased. And I said, Rod, how often do you ever see plaque or blockages once the artery has dived into the muscle? His answer, never. Which is so exciting because it tells us that when those patients come in and they have this chest pain and angina, once they start doing this correctly, they release this spasm because here there's thousands of these interconnecting vessels that really are contributing to this vasoconstriction because of endothelin and thromboxane. And once you can get rid of the endothelin and thromboxane, they all dilate. And this is why they get this tremendous result.
Right.
Yes. And don't you think there's a bit of an improvement in the viscosity as well, very quickly?
Yeah.
Yeah.
Absolutely. No problem.
Dr. Breakey, you have a quick comment?
Yeah, real quickly, I agree. False, false, false. And thank you, John, for asking these questions. But it's because these are common myths, common misconceptions. I mean, I remember when I first came out of residency, a woman with a cholesterol of 302 came in. A month later, she said, recheck it. And I said, it's too early. It won't have changed yet. And it came back 197. I said, what did you do? She said, well, I met with this dietitian. I did what you, and she told me with whole food plant-based. And early on, 35 years ago, I learned what Ted and Dr. Essie and we all know now is that the body goes into healing mode, and this can happen very quickly. So thanks for asking these, and these are clearly within our purview to make change quickly.
Yeah, no, I agree. And I'm going to, as the moderator, I'm going to jump here just quickly. For number 7, we certainly see that with our 15-day whole food plant-based jumpstart, which is, as you may know, is based on Dr. Esselstyn's very low-fat whole food plant-based diet. I still remember very vividly back in 2018, our first patient who came in back when before the pandemic, we could do finger sticks. her total cholesterol was 299 on day number 1, and on day 15, her total cholesterol was 149. It dropped 150 points, right, in 2 weeks. And, you know, since then, we've seen a few people drop in the, actually over 200 points. They were really high cholesterol. They were on the 400. So actually, the people with the worst numbers are the ones who actually get the most benefit, honestly.
Thank you.
Yeah.
Exactly.
Yeah.
So these aren't only false, they're very false.
Yeah,
That's right.
Okay, well, let's see here if I can go on.
All
to the
right.
next. So, all right. So what would be your expected 1 to 2 week clinical outcomes then, since we've established that things can happen quickly and so forth? And so I'm going to show the results here. This is a very busy slide, so I won't focus on that, but I've taken Ted's advice and I've made here's where the money is these are graphs that are looking at the change in the different biometrics on the left. And the dark blue is the beginning. And so these, for example, the cholesterol, this person was into almost the top of the red. But in 14 days or 2 weeks, cholesterol was down into an optimal range. And what we're talking about here is the cholesterol, you can see on this slide, went from 156 to 93. That's the total cholesterol. And so, again, I'm going to just go on here. So you can see basically there's a tremendous amount of drop in the biometrics on the left side. I'm sorry, the biometrics, my apologies, are over here. Oh, I got these backwards. So what I'm looking at on the left is actually the change in intake, cholesterol intake, high-fat foods, etc. So these were the lifestyle habits that we measured, okay, and where they started off and where she ended up in 2 weeks. So really a fantastic change. So let me go back here and straighten out my mess. So I was really looking at this slide over here. And this is the one that's the lifestyle habits. All right, then on the right side here is the biometrics. So lost a little bit of body mass. We didn't get a second waist measure, so I couldn't compare the waist. Systolic blood pressure dropped, still up high though, and glucose dropped dramatically, and so forth. So bottom line is the mean drop was close to 50% drop in these measures. This is the quality of life scores before and after. So you can see the first score in about the middle of the slide. That's the intake. You can see the score 2 weeks later is just over from that. So physical functioning went from 15 to 65. If we go down to the total score, it's 28 went to 77. And 75 is the threshold for considered to be, normal or adequate functioning. So quite a remarkable change. The Beck depression score, the raw score went from 13 to 2. So even though she was not in a depressed range, she had tremendous improvement in 2 weeks as well. Well, I don't know if you wanted to discuss any of this or not. I'd like to go on and discuss it when we look at the 14-month, if that's all right.
Yep. Continue. That's great.
Yeah. So I just have a quick short definition here. Intensive therapeutic lifestyle change, or what we call ITLC, is a high-dose multifactorial lifestyle intervention with a high amount of patient contact hours, making a large change in lifestyle habits in a short amount of time, with close monitoring and deprescribing of medications as necessary. And some of the common modalities here in ITLC is minimally processed whole plant food diet with little, if any, cholesterol containing foods, which of course cholesterol containing foods are all of animal source. Fasting and reduced consumption using sometimes portion control, although I don't use that except in extreme cases. Water fasting or intermittent fasting, use intermittent fasting always. And it's what's called early time restricted feeding, or now it's being called time restricted eating. So eating and your last meal usually by 2 or 3 in the afternoon. And so you end up with a over 16-hour fast before breakfast. Number 3 here on this list, abundant, regular, moderate exercise with gradual increase from inactivity, because if we go too fast, they get muscle soreness and cannot really exercise. Oops, I'm sorry, I forgot the adequate restful sleep. And I like to have them have a bedtime well before midnight with early rising. And that has more to do with hormone production. There's a number of hormones that seem to be released in the early part of the sleep cycle. And there's evidence that they are more productive if before midnight. Generous hydration. It's water drinking and being hydrated is amazingly important, especially for people with pain. It helps tremendously. And we have them avoid sweetened beverages and minimize juices even. Water is the ideal beverage for an intensive lifestyle intervention. We do stress management education. And so those who are really having trouble, we'll actually do some one-on-one sessions or small group with cognitive behavior therapy. We use peer group dynamics with the patient supporting one another, because there's again some published research showing that as social beings, we actually make more enjoyable and more dramatic change with our peers. And then spiritual emphasis on purposeful living. We don't get into religion, but we do get into the fact that we're spiritual beings, and meaning and purpose really do have a lot to do with how we see ourselves and feel about ourselves. So, did you want to talk about any of those at all? The next thing that we're going to do is look at the 6 to 12 month outcomes.
Yeah, why don't you show us those? We'll come back to it. Then we'll get into a discussion.
Okay, sounds good. So we're going to look at the same thing we did before, except now we're looking at, notice the date was December the 6th. So this is about a week ago or so that we got the lab results and had this person fill out the same questionnaires again. So what we're looking at on this slide is we're looking at the diet pattern that this person was eating just a week or two ago, okay, based on the 4 weeks before that. We always ask them, what have you been eating for the last 4 weeks? And definitely, I mean, I love it that this individual, after 14 months, is still on a plant-based diet. You can see there's nothing in the left-hand column, which is where all the animal-based foods are. And then this was the recommendations that our algorithm produces. She still needs to lose 72 pounds, but she's down another 25 from where she was. Her heart attack stroke risk has dropped over 37% since her admission labs. We're not comparing right now to what she was at the end of the 2 weeks, because in some cases she's better and in some she's worse, but we're comparing it to the admission when she was admitted. You can see the C physician there at the bottom just says blood sugar. Her blood pressure is under control at this point. So there's the labs slides. I mean, so let's look at this one. I got it right. The body mass, the biometrics are on the left-hand side, so we can see the change. So again, these white areas are drops from her admission in the beginning of the 2-week program. And she's had some tremendous improvements in the last 14 months. And then over here on the right is the dietary thing. So her fat intake has gone up some. She's eating more fat than what she was at the end of during the intervention, but and a little less water. She's not as well hydrated. Her sleep has gotten worse, and I asked about that, and apparently her husband had, for the last month or so, he's had a number of problems and been in the hospital and so forth, and she's not, so that's probably a temporary problem.
John,
So,
what happened to her glucose?
oh, yeah, it's well, now her glucose over here on the left-hand side. What happened was it had dropped down to a lovely number, but it's back up. In fact, if we go up here, do I have that? No, I don't have that. Let me see. Yeah, I'm sorry, I don't have it. I dropped that slide because it was so busy. But the bottom line is, what I found is that she's been stressed. It's been affecting her sleep. It's been affecting her eating. So her glucose numbers have gone up. they're actually a little bit worse than they were on admission.
So
So
she's over 260?
yes, she is. She's over 260 at
Mhm.
this, as of this reading. This is fasting serum glucose taken about a week ago.
Mm.
And so the bottom line is that when she saw this, it was a real eye opener. She didn't realize that. And anyway, bottom line is she got careless, but she was motivated when she saw these labs that she's got to get back on the wagon.
Hmm.
So here's the quality of life and Beck scores. Again, this is looking at the intake, October 12, and then her current number in December of 2024, and she's doing much better. She's got a total score of 91. I think that's part of the reason that, you know, high blood sugar, especially as someone that's had it in the past, doesn't have any symptoms, unfortunately. Sometimes you have polyuria, but she wasn't noticing any. And so I think that her higher quality of life is sort of hiding for her the fact that not everything is good. Let's compare it to then, now I'm just added on the right-hand side. These were the numbers that she had at the end of her 2-week intervention, and her score was 77. So it went from 28 to 77, which was a 180% increase. But now in December, it's even higher yet. It's 91, and she's up 230% over where she started. So she's been making progress, but her blood sugar is a big problem right now. Oh, I just want to say, so these are this is our program, startanew.me, and each one of these letters stand for one of the things we use: sunshine, trust in God, air, rest, temperance, abstinence, nutrition, exercise, water, and you.
Well, first of all, thank you so much, Dr. Kelly. That was really terrific. So we had a bunch of questions from the audience. I just need to share really quickly my own slides here. Thank you again. We are a nonprofit. If you know any wealthy donors, we're always looking for more. My wife and I are full-time volunteers, but we do pay our staff a living wage. And we do have a significant number of staff. So would love it if you could make a donation for yourself or encourage one of your wealthy billionaire friends to do the same, because we are here to change the planet. And I'm going to stop sharing now. Please take a look at our website, rochesterlifestylemedicine.org, and the Pale Blue Dot community. And now let's go to some Q&A. Is Dr. Graff still here?
I'm here.
Okay.
We've had a couple of interesting questions come up, and one of the most recent ones coming up at the end there was roughly how often, as a percentage of patients, do you need to focus intensely on stress relief and individual CBT in the intensive lifestyle medicine programs? I feel like this may be a more significant barrier to health than we are used to addressing as MDs.
So a question about stress, is that the question?
Yeah, how often, like what percentage of the time is that a major component that needs to be addressed in these intensive programs, and is it something that hampers people's ability to make forward progress without having that addressed first?
I'm going to ask Dr. Esselstyn that question. Have you had, in your experience with your counseling over the years, do you find that people's stress levels significantly affects their ability to?
No, I think that where the rubber hits the road in all this is, are you able to get compliance with your patient? And everybody has a different technique. And the reason that that I tell patients that the reason that my program succeeds where others may fail is because nobody else is as mean as I am. But, and with it, hopefully that puts a wrinkle in their eye. But when we see if we are going to get patients to adhere in a lifestyle change, we have really got to show them respect. And the only way that I know to show a patient respect is to give them my time. So the present format we've had now for some years is anybody who signs up for the program, it's obviously it's virtual, but when they sign up for the program, they're going to have 2 interventions. One, 2 or 3 weeks before our seminar, which they will be attending. In that seminar, I will speak with them alone, usually for anywhere between 35 to 45 minutes, getting their story, at the same time permitting them to ask questions of me. So they're coming to the seminar, which is a 5.5 hours. We have a strong platform from which we can all move forward. Then at the actual seminar, I get 3 hours. Anne gets about an hour and a half showing them how to acquire and prepare foods. Then we have our son-in-law, Brian, who's head of the Esselstyn Foundation, has a wonderful presentation on food architecture. Then we have a presentation from a former patient who's been 15 years out now, and he's very articulate, and he adds really quite a dimension to the program. And then we end up with a chat room where we answer their questions. But for patients who have a great anxiety in that sort of situation, I haven't really felt the need to deal with them individually, because 99% of these patients who come to our program have a doctor at home. And by the way, none of them are from the greater Cleveland area. So it's not a situation where I can see them on any kind of a frequent basis if they come from Oregon, or if they come from Arizona, or from Canada, or from overseas. So that, but I think that somehow we do address anybody who's got severe anxiety or the need for relaxation. We will offer them some suggestions on meditation.
Can I just comment on that too, Ted? Yeah, I really appreciate the question, and I almost wish I had some heart disease so I could go see Dr. Esselstyn and be one of his patients. But that's, of course, just joking.
It can work at that.
But I do want to say, Dr. Terry, that I think that occasionally I run into a guest, health guest we call them, that has serious issues, and we do some one-on-one. But I totally agree with what Dr. Esselstyn just said. In my experience, and of course, I only do intensive intervention. I'm not a primary care doctor. I don't even know how to do that. But so everybody I see is in a group with an intensive intervention. And so they come to a 10-day program where I see them from 8 in the morning until 7 o'clock at night, 10 days in a row, basically. So we spend an awful lot of time. And I think you're so right, Dr. Esselstyn, that the way if things happen normally, what will happen is at graduation, they will say, I can't believe how much time you guys spent with us. They're just amazed, because of course, most of us doctors in ordinary practice, we're battling the clock for every visit, 7 to 12 minutes, I think, is what I understand is typical. And my goodness, you can hardly sit down and talk about the weather with them. But anyway, so it's quite different. We spend a lot of time, and I just find that it's a good point, but I do believe that the way we've designed our program, it's seldom an issue that we have to do one-on-one. But I have had to do that, and I've even brought a psychologist in, that I don't always have on the team, to help in some cases where there's specific issues, like maybe, home violence is, for example, one that nobody likes to talk about, but it can be really difficult to get your mind off of that problem and start working on, lifestyle changes. The other thing I would say, though, about that is that even the ones that come in with very high depression, anxiety scores, they typically leave with them either in mild or no, it's gone. And it seems that having success at making lifestyle changes, and I believe there's also some, hormones balances that are changed by an intensive lifestyle change. So some of the best results I get when I look at the percent change is in quality of life, SF-36, and Beck scores. If they're quite bad when they come, they have more change than even their cholesterol or their blood sugar usually.
Yeah, and I was just gonna make, I know we're not talking about dementia or mild cognitive decline. But if we think about that as being type 3 diabetes and inflammaging, Dean Ornish study that came out within the past, year of showing those arms of transitioning to a plant-based dietary pattern, daily exercise, group support 3 times a week, and then daily stress management in the form of deep breathing, journaling, yoga, meditation, right? All of that together. So that is incorporating stress management. That's where he saw those positive outcomes for slowing cognitive decline. So I would put that into, I'm sure if we monitor everything, not just looking at cognitive decline, we would have seen improvements in all of them. So just that multifactorial, taking all of that into context.
Yeah, and thank you for mentioning that, because I've been meaning I'm going to add cognitive decline measure to my data that I'm collecting. I have not been collecting that in the past, but I'm going to be doing that going forward.
One other aspect that I wanted to include was, I mentioned it in the 5-hour seminar day that I get 3 hours. Well, what am I doing during that 3 hours? Well, the whole thing that I think is so important for us to get able to get a compliance. I want these patients to understand the causation of their disease. And that is when they destroy the capacity of their endothelial cell to make sufficient nitric oxide. When they get low on nitric oxide, then you suddenly get the blockages in plaque. But it's really so exciting when you almost see a patient from time to time come out in tears now that they suddenly discover that this isn't due to their genes or their stress. It's, it's due to their lifestyle. That they themselves are the locus of control to halt and reverse this disease.
Yeah, so true.
Yeah. This really brings us full circle to Dr. Kelly's original question of, is there a threshold to therapeutic intervention? And there's really 2 components to that. One is, how intensive is your recommendation? And in regular medicine, hypertension guidelines, hey, you start with telling them to cut back on salt and eat more vegetables. Well, most docs don't even get to that point, but if they do, that's not enough to make a difference. And then the intensiveness with which you support them inspire them to stick with it, because we can tell them what to do. Even if we tell them the intensive way to do it, all the more important that we intensively support them, because they go back out into the world where Madison Avenue and rogue studies and propaganda from industries that are supporting this and well-intended relatives telling them they're going to die of protein malnutrition overwhelm them. And indeed, they don't stick to it. And they go back to their doctor, and back to your question of, well, even if you tell them, they won't stick with it anyway. Well, they're right. It becomes a self-fulfilling prophecy because they haven't supported them well enough to do that. And this brings in the importance of health coaches, of support from us as providers, of a multidisciplinary team approach. And finally, Dr. Essie's kind of comment there about their hand-holding reminds me of that scene in Forks Over Knives where Shandera Nation's going into the grocery store, heading towards the chips, and Anne calls her right at the right time. Hey, how's it going? Oh, just heading over for some kale. Thank you, Anne. Thanks for calling. And, it's sort of a metaphor for how your program, Dr. Esselstyn, for John, what you're describing, for Ted, what you do in Jumpstart and After program, and what all of us strive to do in lifestyle medicine is to say, we're not just going to tell you what to do, but also incorporate the why, the importance, like you say, of knowing about nitric oxide in a way that sticks with them, and then the ongoing support external until it becomes internal. And then once it does, it becomes self-sustaining, because people don't want to go back to feeling how they were, to having the numbers they had, to knowing the risks that they're taking. So great session tonight, Dr. Esselstyn. You really brought out so many of those principles of intensive enough therapeutic intervention and recommendations, and intensive enough support to make it stick. Finally, I'd like to just finish with the parable of the small parachute that came up at ACLM from David Katz. He said, if you jump out of a plane with a parachute the size of a postage stamp, or even the size of an 8x10 piece of paper, the mortality rates are 100%. And you can interpret that parachutes don't work, and that even the size of the parachute doesn't matter, because most of the interventions that people recommend are not enough to make a difference. So the kind of difference that we see with Jumpstart, with your me program, with your program, Dr. Esselstyn, are what are truly making the waves here and helping people to see that this is not only possible, but they can do it. So thank you that all contributed.
I have,
to
I
our
have
efforts.
one good night comment.
Sure.
I think that I really feel that we are on the cusp of a seismic revolution in health. And the seismic revolution in health is not going to come about. They're not going to come about from drugs, stents, or bypasses, but it will come about when we in the profession have the will and the grit and the determination really to share with the patients what is the lifestyle, and most specifically, what is the nutritional literacy that will empower them to absolutely eliminate chronic illness. Hi, guys. Good night.
Yeah, thank you so much. Yeah, thank you, everybody. This was brilliant. Thank you, Dr. Kelly,
Thank you,
for
Chad.
the presentation. Thank you,
Thank
Dr.
you.
Esselstyn, for
Thank
joining us.
you.
Thank you, Melissa. Thank you, Bob Breakey. Thank you, Carrie Graff, and everybody who joined us tonight. We'll see you next time.
Yeah,
Thank you,
thanks, Ted.
Bob, Frankie in the background. For